Hello, this is Patrick Merrill, and this is my 2207 primary assessment audio recording. It is 1/18/2019. Okay, so the primary assessment process is pretty much the basis of all care in the field, and this audio recording is basically how I would perform a primary assessment on any patient that I would run into in the field. Firstly, I would form a general impression of the patient. That's pretty much determining if the patient is sick or not. This would be completed just as soon as I laid eyes on the patient. And what it would be based on is the patient's appearance, their work of breathing, their circulation, and also I would take into account the patient's age, their gender, and their race to help me form my index of suspicion as to what's going on. Secondly, I would go ahead and assess the patient's level of consciousness. I would utilize the AVPU mnemonic. Is the patient alert? Is he responding to verbal or painful stimuli? Or is the patient completely unresponsive? Some things that I would use to calculate this is a sternal rub to find out if the patient is alert to painful stimuli, or in an infant, you can flick the soles of the feet. If the patient was alert, I would determine if the patient is alert and oriented to person, place, time, or event. Questions that you can ask to determine this are, what's your name? Do you know where you are? Do you know what day or month or year it is? And just ask what is going on today to determine if they're conscious, alert, and oriented to event. Number 3, I would assess their threats to life. If I saw any threats to life on this patient, for example, an obstructed or non-patent airway, any disruption of ventilation, such as a sucking chest wound or a flail segment on the chest, or a large hemorrhage that could lead to hypovolemic shock if I didn't treat it immediately. Number 4, I would assess the airway. If the patient is conscious and alert and speaking to me, I would assume that the patient's airway is patent. If that's not the case, then I would open the airway using a head tilt chin lift or a jaw thrust in patients with suspected C-spine compromisation. At this point, I would also suction away any secretions that would obstruct the airway. Once that airway was patent, I would look, listen, and feel for adequate breathing, and I would also take the opportunity to smell for alcohol or signs of diabetic ketoacidosis, basically that fruity smell on the breath that we see in those patients. If the patient's airway did not become patent with repositioning, I would secure it using a basic adjunct such as a NPA or an OPA at that time. Number 5, I would assess the patient's breathing. I would assess the rate and rhythm and quality of the patient's respirations. Is the patient tachypneic, hyperapneic? I would also assess for abnormal patterns of breathing, such as Cheyne-Stokes respirations, maybe suggesting rising intracranial pressure, maybe Kussmaul's respirations that we see in some of these diabetic ketoacidosis patients, or maybe Bio's respirations, which would suggest a severe brain injury. At this point, I would also provide supplemental oxygen therapy if the patient needs it. Next off is the assessment of the patient's circulation, looking and feeling for skin color and texture. Is the patient pink, warm, and dry, or is the patient gray and ashen, cold and clammy, diaphoretic? These are all, could be serious indications of what's going on with the patient's circulation. Then I would go ahead and feel for a radial pulse, and if one is not present, then I would go ahead and feel for a carotid pulse. An absent radial pulse at this point would be suggestive of inadequate circulation. So once that's taken care of, I would go ahead and assess disability. I've already assessed level of consciousness, so at this point I would assess the pupils make sure they're Pearl, equal, round, and reactive to light. And I would also take this time and go ahead and calculate the patient's Glasgow Coma score, GCS. After that, I would go ahead and assess the need for exposing any part of the patient's body that I need to further treat the patient. Do I need to remove it to listen to lung sounds, or maybe place some monitor leads, EKG leads? While doing this, I would try to preserve as much of the patient's modesty as possible. And if it's indicated, if this is an emergency that may be a hypothermic emergency or related to shock, I would try to conserve as much of the patient's body heat as possible at this point. And lastly, I would go ahead and decide whether this patient was a load and go patient or a stay and play patient. Would I need to go ahead and initiate rapid transport to the hospital, or could I further treat the patient on scene? So this is my primary assessment audio recording. That's how I would conduct a primary assessment in the field. Thank you very much for taking the time to listen.